Welcome to Wysdom Radio. I'm Dr. Rusty Hoffman, Professor of Interventional Radiology at Stanford, bringing you a direct line to critical research and interventional updates. Powered by AI, curated by experts. Let's get started.
We're here to unpack complex medical guidelines and really get to the core of what you need to know. Today, we're diving into portal hypertension.
And it's a serious issue. When you have liver disease, often cirrhosis, blood flow gets restricted. The pressure builds up in the portal vein system.
Leads to?
Well, it forces the blood to find other routes out. This creates these fragile, swollen veins, varices, usually in the stomach and esophagus. And if they rupture, that's a potentially catastrophic bleed, a real emergency.
Exactly. So our focus today is the latest AASLD practice guidance. We're going to break down the key endovascular strategies that specialists use to manage this. We're talking about TIPS, that's the Transjugular, Intrahepatic Portosystemic Shunt, and also the obliteration techniques RTO and ATO.
And it's perfect timing, really. The technology in this field is moving incredibly fast. We're seeing big shifts. We're moving away from some of the older procedures that had, frankly, higher complication rates. Now it's about more refined, targeted approaches. Think covered stents becoming standard for TIPS, and a whole new generation of obliteration techniques like Pardo and Cardo starting to be used routinely here in North America.
That evolution sounds like the main story. Okay, but before we get into strategies, let's quickly cover the anatomy, the battlefield, as you might say. We're talking about varices, these portosystemic collaterals, basically emergency bypass routes.
That's a good way to put it. And, most of them, the vast majority, pop up in the stomach and esophagus, though the guidance does mention something interesting, ectopic varices.
Right, the ones outside the usual spots, like rectal or duodenal.
Exactly. They're actually quite rare, less than maybe 5% of all variceal bleeds.
Okay, so focusing on the main area, the esophagus and stomach, how do doctors classify these varices? Does that affect the treatment choice?
Absolutely. It really boils down to where they drain. You've got esophageal varices and then a specific stomach type, GOV1 gastroesophageal varices type 1. These tend to drain upwards, often towards the superior vena cava.
And those are the ones usually managed with things like banding, right, endoscopically?
Often, yes. Endoscopic ligation is a common first approach for those. But then you have the other group, the more complex ones, gastrofundal varices, GOV2 or IGV1. These are deeper in the stomach, in the fundus or along the greater curvature.
Okay, and why are they trickier?
Well, the key thing is they often drain through a large, distinct channel called the gastrorenal shunt, or GRS. This shunt usually connects straight into the left renal vein, and from there into the main systemic circulation, the IVC.
So that GRS is the critical piece of anatomy for some of these procedures, the on-ramp you mentioned.
Precisely. Having that accessible GRS is often what makes techniques like RTO possible. You need that path to get to the varices from the venous side. And this difference in anatomy, it really sets up the two main endovascular philosophies we're discussing.
Right. Either lower the overall pressure in the whole system
with TIPS
or go in and physically block off those specific bleeding veins.
Exactly. Obliteration with RTO or ATO. Two very different approaches.
Okay, let's tackle strategy one first. TIPS. How does creating this shunt actually lower the pressure?
So TIPS, the Transjugular Intrahepatic Portosystemic Shunt. It's basically creating an internal bypass. The interventional radiologist goes in, usually through the jugular vein, navigates down to the liver, and creates a connection. They puncture from a hepatic vein, which has low pressure, directly into the high-pressure portal vein. Then they deploy a stent to keep that channel open.
And that diverts blood away from the congested liver and varices.
Immediately. Blood takes the path of least resistance, flows through the stent, bypassing the diseased liver parenchyma, and dramatically lowers that pressure gradient, the PSPG.
It sounds very effective. And you mentioned technology earlier. The guidance is pretty clear now. Covered stents are the way to go.
Oh, absolutely. PTFE-covered stent grafts are the standard. Bare metal stents, they just clot it off too often. The covered stents have really improved how long these tips stay open and working.
But there's still discussion about the size of the stent. The guidance mentions a trend towards smaller 8mm stents.
Yes, that's a really interesting point. It's a bit of a paradigm shift. Historically, the thinking was often bigger's better for pressure reduction, so maybe 10 millimeters.
Right, you'd think maximum flow, maximum pressure relief.
But there's a major downside to shunting too much blood away from the liver. Hepatic encephalopathy, or HE, brain fog, confusion caused by toxins bypassing liver filtration. So the idea with the 8mm stent is to achieve just enough pressure reduction to stop the bleeding, typically aiming for a PSPG below 12.
Ah, I see. So it's a balancing act. Reduce the pressure enough to prevent bleeding, but not so much that you significantly worsen the risk of HE.
Exactly. You're trying to optimize. If that 8mm stent gets the job done, great. You potentially preserve more liver perfusion and lessen the HE risk. The goal is that post-TIPS pressure gradient below 12, or at least a 50% drop from baseline.
What if even 10mm doesn't get the pressure below 12?
Good question. The guidance actually says if you dilate up to 10mm and still don't hit that target PSPG, you should add medical therapy, non-selective beta blockers to help control the pressure.
Okay. Now, TIPS is a major intervention rerouting blood flow. There must be patients who just can't tolerate it. What are the absolute contraindications?
Yeah, there are definite red lines. Severe heart failure is a big one, an ejection fraction below 50%. TIPS increases the volume of blood returning to the heart, and a failing heart just can't handle that extra load.
Makes sense. What else?
Another one to consider is pulmonary artery hypertension with mean pulmonary artery pressure greater than 45. Same reason the right heart can't cope. Also, active uncontrolled sepsis is a no-go, and severe hepatic encephalopathy that's already present and not managed. You wouldn't want to make that worse.
And speaking of HE, even with careful sizing, it's still the main complication.
It is. It occurs in roughly 30 to 50%. It's a significant issue. Management starts with medication lactulose rifaximin. But if it's refractory, if the patient remains significantly impaired despite meds,
Then what?
the specialist can actually go back in and intentionally narrow the TIPS stent, a procedure called recalibration or reduction to decrease the amount of shunting.
Interesting. One last point on TIPS. What about chordal vein thrombosis? A clot in the main vein, is that a contraindication?
Not necessarily if it's a bland, non-cancerous clot. In fact, interventional radiologists often tackle both at the same time. They can recanalize, basically drill through the clot, and then place the TIPS. This is often crucial for patients awaiting liver transplant, as you need an open portal vein for the surgery.
Okay, let's shift gears to strategy 2, obliteration, RTO and ATO. You said this is conceptually the opposite of TIPS regarding pressure.
That's the absolute key takeaway. Obliteration techniques like RTO block off the varices and the large shunts draining them, like that GRS we talked about. By closing off these major escape routes, you force blood back towards and through the liver.
So unlike TIPS, which lowers the portal pressure gradient, PSPG, RTO often increases it.
Correct. It redirects flow back into the high-pressure portal system.
Why would you choose a strategy that potentially increases the pressure in an already hypertensive system?
It comes down to the trade-offs again. While RTO might worsen things like ascites or underlying esophageal varices because of that increased pressure, it often leads to improved liver function because more portal blood is perfusing the liver. And crucially, it has a significantly lower risk of causing or worsening hepatic encephalopathy compared to TIPS.
So you might accept a higher portal pressure to protect the brain and potentially improve liver function.
Precisely. It's often chosen for patients who already have significant HE or who are at very high risk for it, or maybe have heart issues.
Okay, let's talk specifics. RTO, retrograde transvenous obliteration. You mentioned it depends on the GRS.
Yes, RTO needs that accessible shunt, most commonly the gastrorenal shunt, to get access. You approach the varices backwards from the systemic venous side, usually via the renal vein. It's primarily used for those difficult gastric varices, GOV2, IGV1, and sometimes ectopic ones if they have the right drainage.
And historically, this procedure, BRTO, was quite involved.
Oh, yeah. Traditional BRTO, balloon-occluded RTO, involved inflating a balloon in the shunt to stop outflow, then injecting a sclerosing agent to thrombose the varices. But the balloon often had to stay inflated for hours, sometimes even up to, 36 hours, which meant
ICU stay.
Definitely prolonged immobilization, risk of shunt rupture, potential toxicity. It required intensive monitoring.
But that's where the newer techniques come in, Parto and Cardo.
Exactly. This is where the evolution is really apparent. Parto is plug-assisted RTO, and Cardo is coil-assisted RTO. Instead of just relying on a temporary balloon and liquid sclerosant, these techniques use mechanical devices, vascular plugs or coils, to permanently block the main outflow shunt first.
And that changes things how?
Dramatically. Once the plug or coil is in place, the outflow is controlled. Then you can inject something safer, often just gel foam slurry, sometimes with a bit of thrombin, to fill the varices themselves. There's no need for prolonged balloon inflation, no need for the potentially toxic sclerosant in the same way. It eliminates the mandatory ICU stay, significantly shortens procedure time, and has a much better safety profile.
That sounds like a huge improvement for patients and hospitals, from potentially days in the ICU to a much more streamlined procedure.
It really is transformative. These device-assisted RTO methods are becoming the preferred approach for obliteration when the anatomy is suitable. Now, what if RTO isn't feasible? Maybe there's no GRS, or it's inaccessible.
Then you'd consider ATO, Antegrade Transvenous Obliteration.
Right. Antegrade means approaching forwards. Access is usually gained percutaneously, directly into the portal system. That might mean going through the liver, transhepatically, or sometimes through the spleen, transplenically. Occasionally, you can even do it through an existing TIPS if one is present.
And the goal with ATO?
The absolute goal is complete obliteration. Because you're coming at it from the feeding side, you have to block off the varices and their inflow vessels. If you leave inflow channels open or only partially treat the varix, the rebleeding rates are very high. It has to be a definitive closure.
Okay, this makes sense. Two distinct strategies. TIPS for pressure reduction and RTO/ATO for obliteration. Let's bring it back to the bedside. Patient comes in bleeding. How is the decision made? For standard esophageal varices or GOV1?
If endoscopic treatment fails, TIPS is generally the main endovascular option.
And timing is key, especially for sicker patients. You mentioned preemptive TIPS.
Yes, the guidelines strongly recommend considering TIPS early, within 72 hours for high-risk patients. High risk is specifically defined generally child PUC patients, scores 10 to 13.
Those are patients with very advanced liver failure, right? High bilirubin, poor clotting, ascites, maybe some encephalopathy already.
Exactly. Very decompensated, high short-term mortality risk. Or child PUB patients, scores 8 or 9 if they're actively bleeding when they first have their endoscopy. Getting TIPS in early for these groups can improve survival.
But there's a point of no return, too, where TIPS might be futile.
Yes. Trying a salvage TIPS in someone who is profoundly ill, say a MELD score over 30.
MELD being the model for end-stage liver disease score, factoring in kidney function, too.
Right. Or a child PUC score over 13. These patients are often just too sick to tolerate the procedure or benefit from it. The only real exception is if TIPS is being done explicitly as a very temporary bridge to an imminent liver transplant.
Okay. Now for the real crossroads. Yep. Those gastric varices, GOV2 IGV1, or the ectopic ones. Here, both TIPS and RTO are considered first-line options. How do you choose?
This is where patient factors and, frankly, local expertise really matter. You'd lean towards RTO. Well, if the patient has a history of hepatic encephalopathy, you'd want to avoid TIPS if possible.
Because RTO has lower HE risk.
Correct. Also, if the patient has significant heart problems, RTO is safer from a cardiac standpoint. And sometimes, if liver function is poor but not end-stage, RTO might be preferred, hoping the redirected blood flow improves liver perfusion.
Okay, so factors favoring RTO are prior HE, cardiac issues, maybe borderline liver function. When would you favor TIPS for these gastric or ectopic varices?
You'd favor TIPS if the patient also has significant esophageal varices that might worsen with the increased pressure from RTO. Or if they have really bad ascites, fluid buildup that's hard to manage, RTO will almost certainly make ascites worse because it raises portal pressure. TIPS would help the ascites.
So it's a complex calculation based on the dominant problem, bleeding versus HE versus ascites, and the patient's other conditions. What about those rare ectopic varices specifically? Rectal, duodenal?
For those, the guidance suggests TIPS alone often isn't enough. The varices themselves can be really robust or complex, so the recommendation is generally to combine TIPS for overall pressure reduction with direct obliteration of the ectopic varix using either ATO or RTO techniques, a kind of belt and suspenders approach.
Got it. Finally, a critical point for anyone managing these patients post-procedure. If they've had RTO or ATO, what follow-up is absolutely essential?
2 key things. First, within 72 hours, you must confirm complete obliteration, usually with a CT scan, maybe an endoscopic ultrasound. You need imaging proof that the target vessel and shunt are fully blocked. Incomplete treatment means high risk of rebleeding, so you might need to go back in.
Okay, confirm complete closure soon after. What's the second thing?
Because RTO raises portal pressure, you need to check for consequences elsewhere. So about 1 to 2 months later, a follow-up endoscopy is recommended specifically to look for new esophageal varices or worsening of any that were already there. You need to monitor for that pressure shift effect.
Wow. So this deep dive really highlights how sophisticated managing variceal hemorrhage has become. It's not just one procedure fits all. You have these two fundamentally different strategies. Tips, lowering pressure but risking the brain, versus an RTO/ATO for obliterating the vessel locally, protecting the brain, but potentially raising pressure elsewhere.
Absolutely. And there are still big questions. We really need more head-to-head trials, especially randomized controlled trials, directly comparing modern tips versus modern RTO techniques like Parto-Carto, particularly for different types of varices. And in different patient groups, like the growing number of patients with NASH-related cirrhosis, we need better data to guide those choices definitively.
What strikes me most is that technological leap you mentioned earlier, going from procedures needing days in the ICU with toxic agents to using precise plugs and coils, making these interventions safer, faster, and less resource-intensive. It's a huge shift towards minimally invasive precision.
It truly is. It's moving from sort of broad hemodynamic alteration to very specific vascular targeting. And that, of course, increases the need for specialized expertise, understanding the intricate anatomy, the device nuances, the hemodynamic consequences of each choice.
Which leads to a final thought for you, our listener. As liver disease unfortunately becomes more common worldwide, the demand for these complex procedures will only increase. So the provocative question is, how quickly can healthcare systems adapt to ensure the necessary multidisciplinary expertise, the hepatologists, the skilled interventional radiologists, the surgeons, is available everywhere to consistently deliver this highly individualized high-tech care? Something to think about.
A crucial point for the future.
This is Dr. Rusty Hoffman, and that's a wrap from Wysdom Radio. Find cutting-edge insights through our rapid-fire videos and community forum at medicalwisdom.ai. And remember, knowledge is the best medicine.